Good evening, everyone, and welcome to tonight's webinar. My name is Adam, and I'll be your moderator. Dr. Robert Peskin is our speaker tonight, and he'll be discussing local anesthesia administration and strategies to help ease patient fears. Tonight's webinar is also sponsored by Septidont. If you've attended previous webinar with us, you may have noticed that our webinar console has changed. I'd like to highlight some features that will enhance your viewing experience. If at any point you have a question, please type it into the box labeled "Have a Question." To talk with other attendees, navigate to your control panel at the bottom of your screen and click the chat icon. All right, Dr. Peskin, welcome.
Thank you very much, Adam. And welcome to all of you who have come to visit with us this evening. Hopefully you'll find the next hour or so very enlightening to a certain extent anyway. Just a little bit about me before I get started. I'm a New Yorker. I was born and bred on Long Island. In fact, I grew up in a town called Cedarhurst, which is in the shadows of what we used to call Idlewild Airport, now familiarly known as JFK International Airport. Did some undergraduate studies at Queens College in the city of New York. And after 3 years, I kind of dropped out to begin my dental school career at Stony Brook and had the good fortune of being in the first graduating class from the State University of New York at Stony Brook's dental school. I went on to do both a general practice residency and then a dental anesthesiology residency at Long Island Jewish Medical Center and its Queens Hospital Center affiliate, and I moved into a practice in Rockville Center, New York in 1983, moved it to Garden City, New York in 1994, and have been practicing there ever since. Somewhere along the road, I began my involvement with the dental anesthesiology residency at Wyckoff Heights Medical Center, which I did for about 7 years. As a New Yorker, you get certain, comfort levels with your teams. And I don't know, this has been a good week. We had a very good draft for the New York Jets, although there hasn't been much to speak of the last few years. My Mets are doing great out of the box. Maybe we'll have either a Mets-Yankees or something like that going down the road, but we can only hope. And I guess my biggest passion is hockey and the Islanders. And unfortunately, my team was not able to compete in the playoffs this year, although we did get a brand new arena that is just a sight to behold. And if you get to New York, it's a place you should really put on your calendar. New York is replete with golf courses. Long Island is for sure. And the Bethpage Black is probably the only golf course I'm aware of that has a black box warning. But it's a fun place to play if you have a chance. It's a walking course, but it's really good. So I'm a general dentist and a dentist anesthesiologist practicing in Garden City, although I do provide anesthesia services for other providers in and around the greater New York metropolitan area. I've been very active in organized dentistry. I served in the ADA's House of Delegates every year since 1992. I served on its Council on Dental Education and Licensure and got appointed chair of its Committee on Anesthesiology for 2 years. I also have served at the state level at New York State Dental Association, on the Council on Insurance, on the Council on Dental Education and Licensure, and Board of Governors, and was honored to have been elected the NISD's very first Speaker of the House after a reorganization of its governance. I've also had other affiliations with the ADSA, American Dental Society of Anesthesiology, and Special Care Dentistry Association. But I guess the thing that has most recently occurred is I've been elected Speaker of the House of Delegates of the Academy of General Dentistry. So in terms of disclosures, I think it's important to say that I have been at times a paid consultant. I was at one time for Aura Pharma, and I am today still for Septidont. And I've been a lecturer on the subject of risk management, not pain management, but risk management for both the New York State Dental Association and the B&B Protector Plans. We're going to spend the next few minutes talking about pain management, in particular, managing pain for your practice. And this kind of gives you somewhat of a roadmap of where we're going. We're going to begin by just kind of getting a sense of why is it that patients are reluctant to go to the dentist? We don't necessarily put ourselves in our patients' positions, but they don't like sitting in that chair. It's very anxiety provoking, and for a lot of good reasons. As a dentist anesthesiologist, I get a fair number of referrals to my practice for people who are either anxious or apprehensive, or maybe are even special needs patients. And treating them with a certain amount of tender loving care is a very important thing. Sometimes we have to go down the pathway of using intravenous sedation or anesthesia for them. But we should be able to manage most of what we're being asked to do with local anesthesia. Of course, the reason for all this concern is that the needle is probably one of the greatest fears our patient populations have. They are always asking, is this going to hurt? That's kind of among the first questions we always have to address. And sometimes it's going to hurt, at least in their mind, it's going to hurt. They have anxiety, which can somewhat be uncontrollable. I have a patient that was in the office last week who was there because of a bad experience as a child. Their anxiety level was through the roof. And then, of course, it's the noises of what we're doing, the drill, what they consider to be the weapon of destruction. Well, it's a terrifying thing if you're on the receiving end of it. And the fact that we're really invading personal spaces. There's a lot of emotion that's fully charged in the head and neck region, and we're right in there with them, and that's something that seems a violation in many minds. There are sounds and smells that kind of get accelerated and accentuated when they are in our offices. And, there are other reasons why people will avoid dentists. That could be a matter of cost. It could be they don't like being lectured to, feeling guilty that why has it been so long since they've been in the office, or, having to wait in order to get the services that they came to be provided for. But of course, it's also the bad memories. And these last a long time from childhood, as I've alluded to earlier. So out of all of these, 70% of them relate to actual pain management. So with that in mind, I would think it's kind of important that dental treatment be rendered to patients in as much a pain-free environment as possible. How do your patients judge you? How do they judge if they're in a pain-free environment? Well, there are a lot of things that we can do as a team to try to make it more comfortable for them. We want to establish a team that's warm, that's professional, that exudes a certain amount of caring as far as their ability to undergo whatever procedures are going to be necessary. But of course, their major concern is they do not want it to hurt. And what's going to help that along? Well, the first thing that they're going to be interacting with is what we can hopefully give as a painless injection. So let's talk a little bit about basics. How do we use local anesthesia as a management tool in trying to ameliorate the amount of anxiety they may have about having their teeth taken care of? We're going to talk about it from the standpoint of this holistic approach. And we have to explore this, how to best manage it. What is it that was going to reflect best on you as the practitioner? So, what is pain? It's an important communication tool, and it's really more than just a physical sensation. Nobody loves it. And we know that it represents an effective communication tool that cannot be just limited to the physical sensation, because there is both a physiological as well as a psychological component that come into play. In addition, let's see. Oh, there we go. So we have to deal with the physiology of pain as well as the psychology of pain. Now, for sure, there are pain receptors and pain stimuli that create a chain reaction. It boils down to this interaction between the stimulus itself and how that message gets transmitted through the neural network back to the brain, where it's perceived as something uncomfortable. So when nerve cells detect this potential damage, there are nociceptors that are activated, and they transmit these electrical signals all the way back to the brain. So that's a very important concept. And it's the electrical signals that we're trying to somehow or other stir up, mix up, block if we can, so that that information is not being transmitted back to the brain. There's this gate control theory of pain. And when we feel pain, there are receptors that send a message via these A delta nerve fibers and C fibers back to the spinal cord and then onto the brain, where the sensation of pain is registered and processed and then perceived. And it's the gate control theory that says that when pain messages come into the spinal cord and to the nervous system, before they even get to the brain, they can be amplified, or they can be tuned down, or even blocked out. And an example would be when a child falls over and hurts his knee. If he rubs that knee, the signal from that sensation may actually ameliorate the whole pain experience. But for every one of us, the experience of pain does vary. Severe pain quickly gets your attention and produces an even stronger physical response. And when it comes from the head and neck region, it's even more difficult to ignore than pain that originates anywhere else in the body. Severe pain is strongly perceived, and pain from the head is really, really challenging. So we want to have to deal with it. Well, we are the ones that have to deal with this the most because we're dealing with dental pain. There are many conditions that we're dealing with. Dental pain comes in many shapes and sizes. Pulpitis, acute and chronic, dental hypersensitivity, periodontal conditions, pericoronal abscesses and odontogenic infection, dry sockets, pulpal necrosis, periapical abscess, all issues that stimulate a really aggressive response to pain. So when we talk about decay, well, of course, decay will start off in the enamel where there is more mineral content and will progress if it's left unchecked into the dentin where it is a higher organic substance. And ultimately, if again left unchecked, it will enter into the pulp, which is not only highly vascularized, but very neurologically rich and can cause an area that's confined to become infected. And if that infection does not have a way to escape out through the crown of the tooth, will exit through the periapex, and that will cause stimulation down there, which can result in pain. Dentinal tubules are that pathway between the enamel and the pulp. And there are the pulps containing nerve fibers and odontoblasts, which are also very sensitive. What we know is that dentinal fluid movement disturbs these nerve fibers, and that it's the odontoblasts that move, creating impulses in the nerve fibers that result in a sensation of either minimal sensitivity, expanding all the way out to full outright pain. Periodontally, we understand that the gingivitis is also painful, or can be, but it can be reversed with treatment. There's soft tissue necrosis that can occur, as well as ulceration. Periodontitis is an evolutive and process that also needs intervention. And then we can run into issues with bone loss and the periodontal attachment being lost, which could result in dentinal sensitivity from more exposure of the cementum. And then all of these can be very, very easily triggered, not only by sweets or by cold or temperature changes, but by the work that we do. There are other things that we have to deal with as dentists. Pericoronal dental abscesses, as I mentioned before. That can start as a decayed tooth, where there are bacteria that will progress to the pulp, but it also can evolve from a increased growth of soft tissue over a third molar that can end up being traumatized by an opposing third molar and create an abscess that has to be dealt with. These types of things can trigger severe pain. Dry sockets are another area that we have to be particularly aware of, as well as just periapical abscesses in general. So when we're dealing with the physiology of dental pain, understand that when a patient presents to the office, especially on emergency, the thing that's probably driving them into your office is the experience of pain. Again, sensitivity and decay can be the most common triggers, but there are many other conditions that exist. And we also have to be sensitive to the fact that what we do can result in post-treatment pain. The important thing is to be able to explain to our patients in the most understandable terms, not only what has happened that has resulted in them presenting to your office, but what they can expect to happen once they leave your office. And it's our job to make sure that in doing this in a way that's as courteous as possible and as compassionate as possible, they get the sense that you're trying to help them. Now, of course, there's dental treatment itself, which causes pain. And we can see that this dentist here is armed and ready. He's ready to place an injection of local anesthesia into the patient's mouth. And if successful, hopefully all of these other procedures will not create any pain. But it is possible that doing fillings or root canals or grafting procedures or any of these other procedures, if we don't have good pain control from local anesthesia, they certainly can cause problems. But again, it's the interpretation of pain that we have to deal with. So it's that physiological response, but it's also a psychological response. And for most patients, it can be very personal. For them, the injection is probably the thing they fear the most, but there are other factors that come into play as well. Demographics, age, sex, social and cultural influences all have an influence on the way people interpret it. And of course, those previous painful experiences that they may have had when they were a child, the mere fact that you're there in your office is stirring up all of those memories, which are not necessarily going to be most pleasant for them. Then, of course, there's the expectations they may have towards pain. I mean, how many times have we had patients that grip the arms of a chair as if they're going to break those arms free from the chair because of their concerns and their expectations? It all comes down to their emotional state as well as their physiologic state. So let's talk a little bit about this physiologic impact of psychological pain. Remember that physical stimuli prompt certain feelings and responses. And these have been studied for many, many years. And the psychological stimuli, these can have similar effects. This has all been evidenced by research. So, we have this physiological impact of psychological pain. In an experiment, normal subjects played a video game while their brains were being monitored. And when the subjects were excluded unjustly from the game, it showed that they experienced a distress that correlated with increased blood flow to the cerebral cortex. And that reaction was as intense if they had been struck by a needle. The more comprehensive warning system certainly makes sense from a biological perspective. And the other thing we have to remember is the psychology. The patient's perception of what is going on in their minds is reality. It's not a surprise to find patients with previous painful experiences and those anxious about treatment more likely to report about pain. And interestingly, younger patients and those with higher levels of education do tend to report more on pain than those with lower levels and older patients. So perception is reality. And it's going to be transmitted to us as the dentist in a lot of different types of experiences. It's a cognitive and emotional construct. It's also ironic that the very procedure that allows patients to be treated virtually free of pain is the one that they often fear the most. Dr. Milgram was the one who was responsible for that observation, but for sure, we as dentists can all relate to it. So, we know that dental anxiety makes patients reluctant to enter into our offices, and there are other phobias that can cause patients to suffer rather than visit. They'd rather feel uncomfortable in the confines of their house than have to exit their house, come to a dental office, and deal with it. Research also shows that neglecting dental care can lead to very serious problems, which is the reason why we want to be able to address these problems. And those serious medical conditions that can result include things related to heart disease, stroke, diabetes, and not to mention by avoiding the dentist over a period of time, the costs associated with restoring and rehabilitating a patient's mouth that has been stricken by rampant caries or periodontal disease can be quite extensive. So these are the things that we have to be cognizant of. How do we manage pain? How can we best manage pain? Well, we have to employ, or we should employ, high quality pain control into our practices. Some of these things are going to relate to the actual products that we use, and some of them are going to relate to strategies that we employ as well. So from the standpoint of local anesthesia, understanding that compromising on quality is really not a great idea. In fact, it could be detrimental not only to your patients, but to your practices as well. So your experience and your expertise is primary. And you want to use what's best out there in order to minimize the amount of pain that you can possibly, as well as you possibly can. And local anesthesia, for a lot of people, starts with the use of topical anesthetics. And many of them are benzocaine-based, such as the Hurricane product you see here in the upper right here. And diclopro, which is a diclonine and has kind of not been around for a long time, a product that Septodont recently reintroduced, is another type of local anesthetic, topical local anesthetic, which is very effective in providing a certain degree of topical anesthesia. Now, of course, it's only going to deal with a couple of cell layers, and it's going to be your technique that's going to minimize the amount of discomfort with the injection. But clearly, all of us are used to using topical anesthetics ahead of administering the local anesthesia. Remember that Hurricane being benzocaine, ingestion of that in very high quantities can cause problems. I actually saw something circulating today from, I believe it was AGD Impact, talking about the fact that benzocaine may be one of the things we should think about replacing with other agents. And there are other agents such as diclonine and topical lidocaine that we can use. In terms of administration of the local anesthesia, there's a lot of modalities that we can use. The local anesthetic syringes themselves, from the time that I went to dental school, there's been a tremendous, diverse number of instruments that have been introduced. If you look here, you see that Septodont has a series of syringes, all of them with different size rings that will basically fit the hand, a smaller hand, and really be more adaptable to the individual. And I think that's something for us to consider. The syringes that were around 40 or 50 years ago have been upgraded to a great extent by these newer devices. And they provide for very good control during the ejection and help you to really minimize the speed in which you give that local anesthetic. There are also self-aspirating syringes, and that gives you very good control as well. Aspiration is probably the key in order to avoid intravascular injections, which can have side effects that patients are not comfortable with. So we really encourage you to be aspirating with whatever syringe you're using. Over the last 25 years or so now, we've had another group of devices that have been introduced into our practices. Many of you will recognize this as the wand. It was first introduced in 1996, and it was kind of a cumbersome device with a console. A sleeker design was introduced about 11 years later, also considered the wand, now the wand STA, providing for dynamic pressure sensing technology and a countertop placement. But with this and the foot pedal that's attached to it, it's not something that's going to be portable from operatory to operatory. And similarly, you have to use a proprietary handpiece, which adds additional cost to what you're administering. Septodont, a number of years ago, started to introduce this device, this C-CLAD, this computer-controlled local anesthetic delivery system called the DentaPen. And I've been using this in my practice now ever since it was first introduced, and I love it. What it enables me to do is to give essentially a pain-free injection, very controlled, very slowly, Most patients don't even know I'm administering the local anesthetic. I can be looking at them. I don't have to, once it's in the proper place, I can really, keep my hand steady and the injection will just take place all on its own. The good thing about this delivery system is that it uses standard needles, standard dental cartridges, so you don't have to use any proprietary devices to make it work. The other thing is because it's so small and ergonomic, it's portable. You buy one, you have one, you can use it in multiple operatories, and there's no reason why you have to, do anything more than just this. There are other needles available as well. This system, these Ultra Safety Plus XL syringes enable probably a more safe injection because they get capped and then they cannot be reopened again. Probably in a hospital setting, this is something you may say, although I don't know too many dental offices that are using this device. Now, as far as needle design is concerned, there are needles and there are needles. And I don't know that we can really make a big case for changing needles, but I would say this. When you think about the design of the needles, you want something that's going to be surgical, and you want something that's going to be sterile. And the needles that Septodonts come up with recently really provide much less tissue displacement, and they reduce patient discomfort because of it. They're sharp, they provide for clean cuts, and they're designed for greater control and less discomfort. And when you compare the various needles, multiple manufacturers, the one on the left, the regular triple bevel, it works just fine. But the nice thing about the Septoject XL needles is it's a larger bore, so you're delivering more solution with less pressure, and it really does provide for a very, very painless injection. Now, the Evolution needle, that's a very intriguing design. And you see that it has multiple bevels to that needle. The good thing about the Evolution needle is that it's not going to deflect when it's introduced into the soft tissue. The thing you have to be concerned about, however, is that because it has such a pristine scalpel design, it can actually cause damage to nerves like a scalpel would. So it's not available in anything larger than the 30 gauge needle, and it's intended only for use as infiltration, not for block anesthesia. I want to make that point again. These scalpel designed Evolution needles should not be used for block anesthesia because of the concerns about inadvertently lacerating soft tissue structures that you can't really control, such as the inferior alveolar nerve or the vessels, both arterial and vascular vessels that accompany that inferior alveolar nerve. So you have to be somewhat careful or selective, I would say, in its use. The other thing to know is that there are many different lengths. There are many different gauges available. It wasn't until recently that I started using an ultra short needle for routine injections. And the reason is because, especially if I need it for any type of soft tissue injection, it really gives me a lot more control. So you have the Evolution needles, you have the Septoject needles, and you have the XL needles. And I think that all in all, you have a wide variety to choose from that could help you to minimize the amount of discomfort associated with your injection. And then, of course, it's the agent that you're using. And, I'm partial to Articaine. Since it's been introduced in 2001, it is probably the primary local anesthetic agent that I've been using. And it's good to know that there is good science behind it that kind of substantiates why it is one of the best local anesthetics available to us as dentists in the United States. It has a favorable pKa, so that provides for a short onset. It's very liposoluble, which means that it's potent and less volume is actually required for it to accomplish what we're trying to accomplish. And because of the way it's protein bound, its duration is is acceptable for the procedures that we want. But the other thing is, because of its chemistry and its short plasma half-life, it's very well tolerated systemically. Now, the data shows that in the United States, 40% of the marketplace is using Articaine. As of December 2019, when it first was introduced, it was a much lower percentage. So it's kind of grown in market share. The other thing that's important to know about Articaine is that it does come with two different concentrations of vasoconstrictors. And the vasoconstrictors are kind of important. I mean, we've always gotten used to the fact that in most instances, we're using epinephrine as a vasoconstrictor. Now, why do we do that? We don't do it to stop bleeding. The purpose of the vasoconstrictor really is to keep the local anesthetic at the site of injection so that its chemistry can work miracles and actually end up providing for conduction blockade. So we need to keep it at where it is, where we inject it. There's some other factors about Articaine which are important. So because its pKa is closer to physiologic pH, it provides for a more active molecular form in a clinical situation. pKa, we know, is a constant value, which is unique for each local anesthetic molecule. And if the pKa is the same as the pH, we know of the tissue into which it's being injected, we know we have a 1-to-1 ratio of ionized to unionized molecules. Remember that it's the unionized molecules that have to cross the epineurium to be able to get inside the nerve so that they can get into a new equilibrium within the nerve, and those ionized molecules which are created then provide for conduction blockade of the nerve we're trying to anesthetize. So for Articaine, its pKa is more favorable in that regard than lidocaine is. So at physiologic pH, there are going to be more unionized forms of the molecule than with lidocaine. And any injected acidic solution, remember, must first be buffered by the body. We'll talk a little bit about buffering agents in a few minutes, but remember that by and large, the pH of the solution, the pH of the body into which we're injecting the local anesthetic solution is 7.4. Articaine is not 7.4, it's 7.8. So there still has to be a certain amount of change between the unionized and ionized molecules to provide for the conduction blockade. But because it's more favorable, a pKa than lidocaine, it acts more quickly. And it's important to understand that. So you have more active molecules. You have more active molecules available. Why does Articaine have a higher potency? Well, its lipid solubility is higher, so the product has better penetration into the nerve cell. Remember that the cell membrane is made up of phospholipids. And every molecule has its proper capacity to go through the lipid membrane. Its lipid solubility. For Articaine, that lipid solubility is more favorable than it is for lidocaine. So the other thing is that Articaine has a thiophene ring, which results in high lipid solubility. It's probably the most potent dental anesthetic and therefore requires less volume. Remember, it is a 4% solution as opposed to a 2% solution, which is lidocaine. I'm going to go back one slide. The other thing I want to bring out about this chemistry as well is the ester side chain. You see as number 3 here. That ester side chain has a lot to do with the way this drug is broken down, and we're going to talk about that in one of the slides to come. I also want to show you, we'll talk about that as we move along. So when you compare Articaine to lidocaine in terms of infiltration, it turns out that as a drug used for infiltration, it is more efficacious than lidocaine is. And that has to do with its diffusibility through cortical bone. We kind of sense this. I've been doing lecture series with friends from Europe and from Canada who have been using Articaine far longer than it was available in the United States. And all of them kind of talked parenthetically about how useful this agent is for diffusibility for infiltration local anesthesia. But there was never any scientific proof. And then lo and behold, in 2007, this article appeared in the Journal of the American Dental Association, which provide clear-cut evidence that when you're doing infiltration anesthesia on first molars, that the onset of pulpal anesthesia is much more profound and much more rapid with articaine versus lidocaine. There have been several studies that bear this out, in addition to the one that was first published in 2007. Why does the drug have less systemic side effects? Well, again, remember, we talked about this or alluded to it, degradation happens in the blood. So the plasma half-life is shorter. And once the anesthetic is over, the local anesthetic molecule really has to be degraded by the body and removed from the body. Remember that most local anesthetics, most amide local anesthetics, are metabolized strictly by the liver. But for articaine, because of that ester side chain I showed you earlier on, it is actually broken down not only by metabolism in the liver, but more importantly, by degradation from pseudocholinesterases in the system, in the body. It's the only molecule containing this ester side chain, so it is degraded in the blood by esterases into inactive forms. And in fact, 95% of the molecule is degraded this way, with only 5% of it being broken down in the liver. And remember what the plasma half-life represents. It represents the time to eliminate 50% of the active drug from the blood. Articaine has the shortest half-life, making its safety profile better. Half of that drug is gone in 23 minutes. That means by the time we get to 4 half-lives, it's all gone. The other thing that provides a certain window of safety is that if you need to re-administer, you are going to have far less likelihood of approaching toxicity if you give too much. What other options? Well, remember that all articaine-based cartridges are not identical either. I kind of alluded to this earlier. When articaine was first introduced in 2001 into the United States, first of all, the box didn't look like this, and the banding around it wasn't gold, it was blue. Since then, of course, the ADA has suggested that all local anesthetics be standardized in terms of the banding on the side of the cartridge. But gold articaine first came in 2001, and it came with an epinephrine concentration of 1 to 100,000. Now, in Europe and in Canada, articaine has been available with an epinephrine concentration of 1 to 200,000 for many years. And this was introduced in the United States in 2006. Some call it silver. This is my go-to local anesthetic. I refer to as platinum. I find Septicaine, articaine, 4% with epinephrine 1 to 200,000 to be my go-to local anesthesia whenever I'm administering infiltration anesthesia. Why? You know, there are issues with patients who have cardiac disease. And there was a publication probably about 70 or 80 years ago, which severely restricted the amount of epinephrine we should be administering to patients who have known cardiac disease to 40 micrograms of epinephrine. Well, that's a little bit more than 2 cartridges of any local anesthetic with epinephrine 1 to 100,000, but that doubles when we use the 1 to 200,000. The other thing which I find even more important is for those patients who are a little bit too sensitive to epinephrine, those that complain about the fact that the epinephrine causes them to feel jittery or feel uncomfortable or that their heart is racing, I have found that 1 to 200,000 almost eliminates that entirely. And I can't remember the last time I had a patient that reported that type of hypersensitivity reaction to the epinephrine. So for those reasons, I've found it to be much more useful. There are other adjuncts that we have available to us as well. And especially when we're dealing with children or we're dealing with patients approaching their later years where they may have early onset dementia or Alzheimer's, or even those patients that are special needs patients. Anesthetic reversal is something to think about because we don't want people to bite their lips or their cheeks when they are numb because of the injuries that could result. In addition, you have patients that go back to work after they leave your offices and they're talking on a phone or they're now doing Zoom conferences all over the place and they have a lip that's droopy and they feel embarrassed and they don't smile. They're not speaking properly. They're not able to eat or drink properly. So anesthetic reversal has become a thing. Oriverse, first introduced in the early 2000s, picked up by Septidon a number of years later, is phentolamine mesylate. And it is very effective in reversing the unwanted lingering numbness after routine dental procedures when the local anesthetic being administered contains a vasoconstrictor, whether that vasoconstrictor is epinephrine, olivine, or Defrin. And the thing about it is, it doesn't reverse it like a light switch. And that's one of the things you have to be very aware of. However, if it's given at a judicious time, at the appropriate time, before the procedure is over, by the time the patient leaves the office, they're starting to feel the freezing that they would get from the local anesthetic starting to dissipate. Usually takes about 30 to 40 minutes for it to start, as opposed to twice or even more than that time frame when they are administered the local anesthetic without having any reversal agent administered. I don't have every patient asking for this. Some patients do, many patients don't. But it is great for me to have it in my arsenal, especially for those patients that are returning to work or come to me as an anxious patient for fear of the inability to swallow or to feel their mouth. So for them, this is a great adjunct that we can use. Other things we have available to us are buffering systems. Now, again, we know that even though the pKa of a local anesthetic is in the 7.8 to 8.1 range, that is not necessarily favorable compared to the body pH. What really slows down the onset of action of virtually every local anesthetic is not the pKa, but rather the actual pH of the solution. Bear in mind that every local anesthetic pH is purposefully low, in the range of between 3 and 4. And why is that? Because it has to have a shelf life. It has to be able to last in your office. The bad news is that local anesthetics with an acidic type of pH that is in this range may actually contribute to pain during the local anesthetic administration. It's like injecting a lemon. And because of the pH being much lower, more acidic, that does have an impact on the onset of profound anesthesia. It slows it down. And what ends up happening is that, especially in those teeth that are inflamed or infected, it can be even slower still. So there was an article written, published in the Journal of the American Dental Association in 2019. It kind of substantiates some of the thoughts we've been having about buffering local anesthetic for many years. As an anesthesiologist working in an operating room for many years ago with medical anesthesiologists, conversation always comes to what did they do to their local anesthetic when they're administering epidural anesthesia or spinal anesthesia or local anesthesia for surgical procedures outside of the head and neck region. And it turns out that many medical anesthesiologists buffer their local anesthesia. Why? Well, number one, it improves injection comfort. It changes that pH from 3.4 to something that more closely approaches what body pH is. But more importantly, at least from my perspective, it also hastens the onset of anesthesia. It increases the dissociation rate, thereby increasing the volume of unionized molecule and allowing that equilibrium between unionized and ionized molecules to occur much more quickly. So those are some of the things that we have available to us as far as our injection technique. Clearly, there are other things available to us as well. Many of us have in our offices nitrous oxide, laughing gas, which we use rather routinely. And what it does is it provides an effective and relatively easy way of relaxing a patient, The great news about nitrous oxide as part of this continuum of the depth of sedation is that it's something that is easy on and easy off. We can put a nasal hood on a patient's face, on their nose, turn on the nitrous oxide, and within a relatively short time, they're starting to feel the effects of it, and they feel much more comfortable. And at the end of that procedure, once everything is done, the procedure is done, we turn on 100% oxygen for a period of 3 to 5 minutes and allow them to equilibrate, and then they're ready for discharge, and they can drive home, and there's no problem. Now, of course, as an anesthesiologist, I would tell you, there are other modalities that are available. And some of you may have been trained in these modalities, whether it be moderate sedation or deep sedation. They're very useful. And I would say that, in general, they do provide a very good way, a tremendous adjunct, to allow the provision of dental services. When you're dealing with minimal or moderate sedation, you can have a patient that is administered sedation. If I was giving moderate sedation, I don't know that I would feel comfortable with them driving home on their own. I don't think that would be appropriate. But clearly, I have someone who I can converse with during the procedure, and I would get a good sense of where they are. That's a patient who's going to be conscious. It's going to be a lower risk type of procedure. But for some of my patients, because of my anesthesia training, and because they are referred to me because of that training, I have to employ deeper levels of sedation where consciousness is going to be something that's not assured. In fact, most patients are going to lapse into an altered consciousness state. That's what I'm intending to do. There is a certain risk associated with it, and I'm aware of that, and I'm prepared for it. But it is something as an adjunct that is very helpful in managing this patient population. So we have all those modalities now, and now we have to think of some of the other things that we can use, some strategies we can use to produce high-quality pain control. I think one of the things that most patients really find untenable is coming to your office for an appointment at 4 o'clock or 12 o'clock or whatever time, and they get there on time and you're not on time. And I think that has a lot to do with the way we manage our practices. Sometimes, something takes longer because of an unexpected or unanticipated complication or whatever. That's okay. But when we have those situations, we don't want to add additional stress to our patients. So the recommendation here is, you're going to run late. The patient's sitting in the waiting room. Be courteous to them. Treat them the way you'd want to be treated. Let them know you're running 15, 20 minutes behind, and give them the opportunity to reschedule if they have to, if they don't feel comfortable sitting in your office longer than when their appointment was scheduled to begin. I think that would go a long way in reducing the amount of anxiety they have sitting in your office. Patients need to relax. So putting them in comfortable chairs, in a room that has a nice environment, that's appealing to their senses, with flowers, that appears less clinical, that has pictures that are not of teeth, but rather of skis or golf course or whatever scenery that makes them feel comfortable and makes you feel comfortable. So it's a good idea that they also not be subject to the sounds of what's going on in the back office. I think a lot of these things will help to enhance their mood and make them more acceptable to what you're providing. The other thing is that you, as the dentist, you have to be a good communicator. Using body language, expressing empathy in whatever way, being a good listener, doing no harm to your patient. Make the visit an experience, not just a treatment visit. And I think that patients will know that if you care, that's more important than caring what you know. I think, of course, it's important for you to be a competent individual and well-skilled and doing everything if that's possible, to be current in your dental skills. But they don't care how much you know. They just want to know how much you care. The other thing is that communication has to extend to the things you're doing. I don't think anyone would feel comfortable if the dentist with his hand on his head and sweat dripping off his brow is looking over you and really just exudes this hyperactive state, because patients don't want to be subject to this. So remember that if there's stress, communicate it with a soft and calming voice. If there's something going on that's not expected, let them know that what's going on. Communicate with them. Don't scare them, but communicate with them. Share with them the issues that then may present themselves to the patient. And of course, make sure you document them properly. That's the risk management side of my brain working in this case. Patients have a hyperacute perception, and no one wants a tired and stressed dentist, at the very least, operating in their mouth. So we also have to think about the practitioner's pain. Now, dentistry is a difficult profession. I've been doing it, thank God, for a little more than 40 years, and I've had a full career. And I like doing what I do. I like being able to combine my intellectual skills with my manual skills and being able to provide procedures for patients that make them better than when they came in. But we have pressures upon us as well. Time pressures, the requirements to increase reimbursement, to increase productivity, especially in this day and age when many of us are working in situations where we're not getting the same type of financial reward we once did from the same procedure. So we have to produce more. And there are other factors of stress: concentration, the noise, the aches and pains, causing aggravation by being put into a position for prolonged periods of time. These are all factors we have to deal with. And there are many dentists who suffer from work-related stress. This is an article, comes from an article published in the British Dental Journal back in 2004. In Great Britain, 60% of practitioners reported being nervy, tense, or depressed. 58% of them reported headache. Some reported difficulty in sleeping or feeling tired for no apparent reason. And what were identified as the main etiology here was the fragility of the dentist-patient relationship, the pressures associated with time and scheduling, and the problems associated with interactions with staff and the technical aspects of what we're doing. We're working in a very small area. We're being asked to do remarkable things on very small teeth, using instruments that without any type of assistance sometimes is not so easy to be able to visualize. So these are all important things we have to take into consideration. So for us, we have to take care of ourselves. We have to be concerned about musculoskeletal disorders, tension, blurred vision, maybe resulting in lower productivity. Sometimes we have to think, if we're suffering chronically from back fatigue or whatever, then maybe we need to seek some professional advice for us in order to be able to continue what we do. I think a lot of this is about introspection, assessing our work habits, making sure that we're doing things in a more comfortable environment, considering the use of ergonomic equipment, taking breaks throughout the day, doing exercise, creating a relaxing ambience that's mood enhancing and calming. The music that we play in the office is not just for the patient, it's for us as well. And of course, we deal with a team. So the relationship that we have with our staffs is absolutely key, because they are our best support. So we have to make sure that that relationship we have with the people that we deal with in our offices, our front desk people, our chairside assistants, our auxiliaries, our hygienists, these are all important relationships which we have to cultivate, and we have to make work positively for us. So what's the consequence for the patient? Well, of course, if we do all this, maybe we'll end up being more productive. Remember that people are not reasonable when it comes to a dental visit. When asked how do they feel about a dental visit, a large percentage of them were anxious, terrified, or at least had some concerns. Only 46% felt comfortable there. So over 50% have anxiety and apprehension. And when you think about what they do when they have to think about going to the dentist, many will avoid, many will delay, some will reschedule, some may even not show up. So pain management absolutely impacts your practice economics. Time spent on patient psychology can be considered wasted, but it really is not. And it will enable you as the dentist to save time during the procedure and the procedures to come, because we want to increase the number of patients we're able to treat. So these soft strategies can be used very effectively. It's an investment for future treatments and in our caring reputation. Remember, rescheduling may be bad. It impacts optimization of your appointment book, but a no-show is worse, and that equates to revenue loss. So while you may be able to use a spot in your schedule for another patient, it may not be the case, and unexpected downtime does not generate revenue. So remember that when you're dealing with your appointment book, be smart in terms of how you schedule your patients. And remember, too, that superior practice skills do not stand a chance against poor pain management. A dentist's reputation is primarily based on whether or not you hurt the patient. Your reputation drives patients to your practice, so beware of the potential negative financial consequences for not considering them. So we talked about physiology and psychology. I'm sure we understand all that. The products that are available for pain control and efficiency, our experience, their experience, the patient's experience versus the actual treatment, and the patient's behavior. And we think about these different profiles. We want to make sure that pain management, whether we are a puppy dog or whether we're a bull, that pain management is an important part of our daily routine, and remembering that empathy is key and the patient experience is the most important aspect. So don't think that only results matter. Don't underestimate the patient's anxiety. Don't overlook the patient's impression of your practice setup. Don't neglect the need for empathy, and don't compromise on pain management product quality. Rather, take pain management seriously, understand that psychology of pain, improve your practice, its look, its feel, deal with your own stress level, and build a caring reputation. So at this point, I think we'll take some questions. I'm going to, there's a email address, webinars@henryschein.com, which you can use if you want to submit them. And I believe that there is a chat box that we have available here. I believe that's the case, Adam, right? And of course, multiple webinars available. Schein. So I want to thank you for giving me a few moments of your time. I hope you enjoyed the presentation. And if anyone has any questions, we have any questions, Adam?
Yeah, we got a couple. If anyone does have questions, feel free to drop them in the Have a Question box or the chat, and we'll get to them. First question here, can you please review the use or concerns of articaine for mandibular block anesthesia, particularly the possible concern for lingual paresthesia?
That's a great question. And, that could be a whole lecture. So I'm going to give you the cliff notes on that. There has not been, in my mind, a demonstrable study which has proven categorically that articaine causes lingual nerve paresthesia or inferior alveolar nerve paresthesia. There are a number of scenarios that have been described or imagined that could lead to that happening, primarily from nerve trauma from a needle. That's not related to the solution itself, but rather to the instruments that we're using to deliver that solution. But all of that said, there are also studies that demonstrate that the efficacy of the success of administering a good inferior alveolar nerve injection is not any different whether you use lidocaine or articaine. So one has to ask themselves, is there an advantage to using articaine? I think for infiltration local anesthesia, for diffusion through cortical bone, there isn't an agent in our armamentarium better than articaine to administer local anesthesia. It can be useful for block anesthesia, and I don't believe that there's a contraindication. But again, you have to just decide for yourself whether or not there's an advantage to doing that. Remember, a good plaintiff's attorney is going to try to draw a conclusion, whether it's based in reality or not. So just be aware of that. Hope that answered that person's question.
Yes, thank you. Another question here. Is there a painless inferior alveolar nerve technique?
Well, that again is a lecture all by itself, and that can be demonstrated with videos and things of the like. One thing I would say in terms of trying to minimize the amount of pain associated with a block, I happen to think that use of the C-clad device, the DentaPen, has really significantly reduced the amount of procedural pain associated with that injection, especially when you're administering it at a medium rate, which is about 60 ml in a minute. I'm sorry, that's wrong. I have to think about the actual the infusion rate. But there's the middle rate, which would be the blue light on the DentaPen. That to me is something that's really going to be very helpful at minimizing the amount of discomfort associated with that. I'm going to take things. Any other questions?
Yep. Do you believe in a 2-injection technique for the interior nerve block, like an infiltration for injection pain reduction?
Are you talking about, well, say the question again, because I'm not sure you know.
Sure. Do you believe in 2-injection technique for the interior, the IAN, whatever I just said, I forget
Okay,
what it spells out.
IAN, okay, that's what I thought you were talking about.
Yes.
The inferior alveolar nerve block. Okay.
Yes.
So that's where we get into trouble with paresthesia. It's been taught in many dental schools that if you administer mepivacaine plain first, that because of its more favorable pKa, that you're going to eliminate the pain with the subsequent epinephrine-containing local anesthetic. But by anesthetizing the area into which the local anesthetic is administered first, and then coming back with a second injection, that's when you will, or you can, administer an injection right into a nerve, whether it be the lingual nerve or the inferior alveolar nerve. And that's when we can get paresthesias, because we're unknowingly injecting into an area that's already been anesthetized. Now, why do we do that? It comes down to this theory that the pKa of the mepivacaine will make the first injection less painful. I would prefer to do it a different way, and my way would be to administer it slowly using a C-clad device and buffering my local anesthetic so I minimize or totally eliminate that bee sting effect that would occur in the absence of the buffering system. So that's my approach to that. And I have to say, I've been using buffering in my practice for 10 years now, and it's been very effective in reducing or totally eliminating the amount of discomfort associated with an inferior alveolar nerve block. Any other questions?
Excellent. Yep, they keep rolling in.
Okay.
There's a comment in the chat that just says Tuttle technique and types of needles and septo.
Okay. So septo is articaine, and we've discussed that at this point. The Tuttle technique is something that I do not have proficiency in. There is a device that Septicaine has that enables one to effectively and without creating stress in the needle, bend it 90 degrees so that it can be approached from the a lateral approach into the bone for intraosseous injection or into the PDL. It's a very useful technique, but I have to admit I am not as well versed in the Tuttle technique as I should be, perhaps. How we doing?
Okay, and looks like we've got just one more as of now, and some more abbreviations, so I apologize. What would be the best option of LA without vasoconstrictor for SRP appointments?
Okay, so let me see if I can interpret that for you, Adam, so that you understand. So what would be the best local anesthetic to use without a vasoconstrictor for a patient who's just having scaling root planing as opposed to having operative dentistry done? And, mepivacaine is the primary non-vasoconstrictor containing local anesthetic that we have available to us. But as I suggested to you earlier, Articaine with 1 to 200,000 is a pretty close lower epinephrine containing local anesthetic. And what I like about it is it's very effective in terms of its diffusibility. So that's a good thing. I mean, there are other techniques that we can use. There is something that's been on the market now called Orachix, which for root planing and scaling is administered as a gel into the sulcus or around the sulcus and can be very helpful for managing patients who are having scaling, who want to have some sense of local anesthesia. And then there are other things we can use as well. Years ago when diclonine was first introduced, there were some people that employed techniques where they had patients actually swishing with diclonine mixed in with whatever, water, mouthwash, to try to provide a certain degree of decreased sensitivity in the soft tissues in the mouth. I don't believe I've ever seen the paper that really demonstrates that well, so I don't want to tell you it's a profound technique that's been researched. But there are other ways we can deal with our patients who are having scaling and root planing done that can be very effective in minimizing the amount of pain associated with those procedures.
Well, thank you for dissecting that. That's why you were giving the presentation and not me.
Okay. You're reading the questions, that's all.
Yes, exactly. How do you give painless pallidal injections?
Palatal. So, again, patients get referred to me for anxiety and for a variety of other reasons, including a very hyperactive gag reflex. One of the things I do, I would say rather routinely, is give a greater palatine block. Now, of course, knowing the anatomy, and that's something that's beyond what we have available to us here, is very important. Using a very fine needle, a 30 gauge needle, sometimes even the ultra short needle, and applying some distracting type of pressure, either with the blunt end of a mirror next to or adjacent where that needle is going to enter into the palatal keratinized tissue, will help to reduce the amount of discomfort. But the most important aspect of that is making sure that that injection is administered slowly. If you use the DentaPen at the slowest setting, I have found that patients are extremely tolerant and receptive to it. And for those patients who have a hyperactive gag reflex where I need palatal anesthesia to place a rubber dam clamp or to take an x-ray or to do a surgical procedure, it's extremely effective in being able to accomplish that objective.
All right. And another comment here, just to be clear, Septicaine is not contraindicated for mandibular nerve block. Is that correct?
There is nothing in let me just back up a second. There are people who have promoted the concept that Articaine should be avoided for block anesthesia. I have not seen anything in the literature which totally 100% provides a medical contraindication to doing so. I think with every technique, you have to demonstrate due diligence. You have to use a proper technique. You have to aspirate, administering local anesthesia into an area and then coming back with Articaine for block to administer the block is not the technique I would employ. I would avoid that for fear of causing the problems of paresthesia. There was an article in Anesthesiology back in around 2004, 2005, which basically came to the conclusion that intraneuronal injections of local anesthesia can cause nerve lysis. That's what we're trying to avoid. So the technique, it's a very technique-sensitive thing, but as long as you aspirate and you go into an area that has not been previously anesthetized and you pay attention to the patient's reactions, I believe you're okay using Articaine for a block. The more important question in my mind is, do I? And I don't. I use lidocaine because to me, there isn't anything in the literature that suggests it's more advantageous to use Articaine for block anesthesia. It's a very complex question, but I hope that answers it.
I hope so as well. All right. I think we got through all the questions. So with that, we're a little over time. So thanks for sticking with us, everyone. Appreciate it. Thank you so much, Dr. Peskin, for the very informative presentation. And of course, thank you to everyone for attending. I certainly hope everyone enjoyed tonight's webinar. We do appreciate your feedback via the survey that will pop up on your screen shortly. And as always, we did record tonight's webinar, so we will email that out to you sometime in the next week. Thank you, everyone. Have a great night.